Continue with talk of Dr. Anil Bansal. Dr. Anil Bansal is interventional cardiologist at Dubai and Sharjah, and previously he was faculty at Wisconsin Hospital, California. Dr. Anil Bansal, you are going to talk on clotting disorders and other hematological issues post-COVID. All yours, Anil.
Yeah, hi. Can you hear me, Chetan?
Yeah, we can see you. You can start share screen and open your slides.
Okay, just hold on. How do I?
First, you open your presentation.
Yeah, I've opened the presentation.
Then you press this green button on the bottom, share screen. On the bottom, green with the arrow.
इसमें वो शेयर वो जो पिक्चर
इसको
इस पे क्लिक करें, इस पे जूम पे क्लिक करें, जूम
इस पे
पिक्चर पे
इस पे
इसमें यार कहाँ गया वो और इस पे क्लिक करें ना, इसमें होगा.
Meanwhile, Dr. Deepti, you are there? Ekta, has Deepti joined?
Yes, sir, I'm here.
Okay.
Sorry.
Yeah.
Stop sharing. शेयर सिर्फ वो अपने प्रेजेंटेशन चूज करना है. ये प्रेजेंटेशन.
Yeah. Jitendra?
Yeah, we can see. Start slide share, Anil.
Yeah. Okay. So you can see the slides now?
We can see.
Okay. So good morning, ladies and gentlemen. So I'm going to talk about clotting because anticoagulants is something which we deal with quite a bit, and it has really increased in the COVID era. I'm going to just start off with a case which I picked up from the August issue of Journal of Stroke and Cerebral Vascular Disease. A 48-year-old man with obesity was hospitalized with severe COVID, complicated with acute respiratory failure, septic shock, and dilated cardiomyopathy and fungemia. Despite treatment with enoxaparin, his D-dimer continued to rise above 20 and continued to spike fevers, and this prompted us to do an upper and lower extremity, which confirmed DVT in both areas, and enoxaparin 1 milligram per kg body weight twice a day was started. The D-dimer decreased while on therapeutic anticoagulation, but 3 weeks later, pending hospital discharge, the anticoagulation was switched to oral apixaban in its loading dose 10 milligram twice a day, but the patient developed acute severe right eye visual loss with no light perception and was diagnosed with incomplete ophthalmic artery occlusion. D-dimer was still elevated to 2.13. Stroke etiological workup showed no embolic source. Resolution of dilated cardiomyopathy was noted with a negative antiphospholipid antibodies. Treatment was changed from enoxaparin to enoxaparin from apixaban, and no further thrombotic episodes were noted. I present this to highlight the amount of thrombogenicity which is available, and what we don't really have an answer is what is the best way to treat, whether it is enoxaparin or the novel oral anticoagulant agents. And the problem is we have to go back to the physiology of the Virchow triad. 100 years ago, Rudy Virchow said that venous stasis, activation of blood coagulation, and vein damage was the three things which was leading to a coagulative function happening in the body. And this is exactly what is happening in the COVID. I know this is something which we don't like to know about, but we have to be aware. The extrinsic and intrinsic pathways leading to the common pathway and then coagulation. I want you to highlight that the extrinsic pathway is much quicker, much more virulent. And in COVID, this is what is happening. If there is extrinsic pathway through COVID virus, which is causing endotheliitis and direct thromboinflammation and direct clotting. So it is a much more virulent form of extrinsic system, which is activating the cascade, leading to the conversion of prothrombin to thrombin, and then thrombin acting on fibrinogen to make fibrin and then subsequent clotting. Now, here is what is happening. The SARS-CoV is causing thromboinflammation and endotheliitis is basically causing endothelial inflammation, which is leading to an extrinsic pathway activation of the coagulation cascade. I want you to sort of concentrate on this. The upper slide is where the inflammation and thrombosis is happening. This is in the milder and the earlier form of COVID, and where the protective immune response has not yet kicked in. So this is from 0 to 10 days of COVID infection. As you can see, a large majority of these patients do become better, and they develop memory of the T cells and B cells, and then it resolves, and the inflammation is not that severe. But when severe COVID happens, that is when the protective immune mechanism of the body, which is through the dead virus, takes over. That is the time when you have a hyperinflammatory phase, especially from day 10 to day 25. And that's when you're getting really into problems of coagulation, of DVT, of massive pulmonary embolism as a major cause of death and morbidity in the ICUs, where we are treating these patients and sometimes on ventilators. Why is this happening? As you know, the SARS-CoV-2 blocks the ACE2 receptors to get into the body, and this causes angiotensin 2 mediated injury in the vessel wall. It also causes complement activation, and this again causes the activation of the coagulation pathway. So again, the extrinsic pathway coming in place and causing hyperinflation, coagulopathy, alveolar injury, and endothelial disruption. This is, I think, a slide for ophthalmologists for you to sort of kind of understand that why is this happening in the venous system. From the Virchow triad, we know stasis is much more prevalent in the venous system than the arterial system. That's why deep venous thrombosis, pulmonary embolus, sagittal vein thrombosis, all kinds of venous thrombosis are coming into play because of the greater amount of thromboinflammation happening because of stasis, because of the greater amount of COVID virus hanging out in the venous circulation and therefore activating the Virchow triad. And what I also want to the direct inflammation which is happening due to COVID is causing tissue factor activation, which is again causing the external or extrinsic coagulation to get activated, which is directly creating thrombin from prothrombin. And it is thrombin which is causing platelet activation and not the other way around. Normally, in the intrinsic pathway, in the acute coronary syndromes, we have the intrinsic pathway, the platelet activation happening, and then plaque rupture is happening, and then thrombin is forming. Here it is the other way around, because here it is an external injury. It's an external agent causing thromboinflammation and and endotheliitis, causing severe thrombus formation and thrombotic inflammatory changes. Again, this further, the thrombin itself is also activating the complement pathway. It is activating again through the plasmin, again acting through creating further thrombotic and inflammatory changes. The question is, what do we do? Now, inpatient, we are quite clear that inpatient, if they're in the ICU, we start them on prophylactic enoxaparin, about 40 milligrams subcutaneous per day. There are now some, if there is a mild elevation of the D-dimer, by the way, D-dimer is nothing but a fibrin degradation product. You know, for you to understand that, it is basically a product of fibrin.
Anil, can you summarize, please?
Yes, sure. And so in this, we have the ultimate pathway from the European Society of Cardiology for patients who are admitted with COVID, with symptoms and high risk of thromboembolism, admitted to an intensive care unit. We can either give them unfractionated heparin or enoxaparin 1 milligram per kg body weight twice a day. If they are low risk for thromboembolism and have a D-dimer which is normal, or a D-dimer above 3 or greater than between 5 and 3, we do an intermediate and low and a high dose. If it is greater than 3, then it is definitely full dose. Otherwise, it is for the intermediate, it is 40 milligram twice a day. And for low dose, low risk, it is 40 milligram once a day. So 40 milligram once a day, 40 milligram twice a day, and high dose is 1 milligram per kg body weight twice a day. Thank you.
That was very nicely explained, Dr. Anil, and thanks for giving us example of so many cases also from the literature. I would now like to invite Dr. Nechalani, sir, to answer some of the questions of these clotting disorders related to our ophthalmic conditions. Do you think, sir,
hello,
in COVID-19 patients? Hello?
Yes, your question was, yes, please go ahead.
Yeah, is there increased incidence of retinal venous occlusion cases in COVID-19 patients?
Yes. We have seen, we ophthalmologists have basically seen increased coagulation, venous coagulation related ocular problems, particularly in older patients. We do get more incidence, but yes, we have seen in the younger age group as well in this post-COVID and COVID era.
And younger patients, even bilateral cases are being seen. And do you think, as Dr. Anil Bansal mentioned, are the clotting disorders and hypercoagulability are the factors responsible for these RVO cases? And what particular factors do you think are to retinal venous occlusion cases in our patients?
Yes, particularly in younger patients, there are two pathologies, as already explained by Dr. Anil. One is a hypercoagulability. Another is a inflammatory process of the vessels, particularly the vasculitis. So these are the two pathologies which lead into a problem of venous occlusion in younger patients as well. And presence of hypertension and diabetes, which are the comorbidities particularly seen in these patients, has increased the incidence.
And do you think we can start some prophylactic measures in these high-risk group of patients with comorbidities?
I would say that we should monitor the hematological investigations, particularly if D dimer is gradually increasing in these patients who were admitted to hospital for COVID kind of problems. We must start with antiprophylactic depending upon these hematological investigations. The ecosprin or anticoagulant therapy, that has to be continued for next practically 1 to 3 months after the COVID, and it has to be re-evaluated again and again by your physician to get rid of all these problems and to stabilize to a normal situation.
Okay. I think with that, we come to the end of this